Live, Facebook Live. We are doing this week glaucoma treatments. Just to recap, we have covered over the last 2 weeks, or the last two sessions, we've covered COVID. Then we've covered glaucoma drops and laser. But today we're covering glaucoma treatments, the surgical treatments of glaucoma. So microinvasive glaucoma surgery, and of course traditional surgery as well. Just while we wait for a few people to tune in, I'll just say the first time I did this, it was very strange having to manage questions and the screen and all the setup. But last night I had to do a webinar to China, and in that setup I had a live translation. The software I'd never used before, it was some foreign software. All my screen controls were in Chinese characters, and I was getting messages sent to me purely in Chinese characters. So even though it's still a little strange sitting here doing this, it's certainly easier than what I've just had to manage. So it's a welcome relief to be back on Facebook Live, that's for sure. So maybe just to set the scene here, when we discuss glaucoma surgery, you usually find that ophthalmologists will fall into two camps in this regard. There will be those that really love traditional surgery, like trabeculectomy and tube shunts, and those that really love newer surgeries, like microinvasive glaucoma surgery. Sometimes there's not as much in between. However, I would say that I love both. So I really love MIGS. For those many of you may know, I was trained by the person who developed MIGS and invented that whole space. But I also love trabs and tubes, and I did some training with someone who is a leading traditional glaucoma surgeon in New Zealand. So I sort of work both camps, and I think it's a good to discuss both and see the advantages of both. I guess I'm kind of like Mitt Romney, right? The Republican who crossed the floor to impeach Trump. In that, I came back from my fellowship in Toronto, having trained with the developer of MIGS, and everyone would think I'm a trabeculectomy hater and that I'm going to be very partisan on this, but not at all. I think there's a really very important role for both. I certainly couldn't deliver the standard of care that I would want to if I only had one at my disposal. And so I certainly use both traditional techniques and newer microinvasive glaucoma surgery techniques all the time, and they both have their advantages and considerations. So it's a big topic. We've run overtime on every single Facebook Live we have done so far, and this will probably be no exception. We'll try and keep it moving along. Sapna's going to send me the questions as they come in. We already have a long list of questions, and I'll sort of work through those. So I would say the question is, you already understand, it's not just is it MIGS versus trabeculectomy or tube shunts, traditional surgery. Both are really important. Neither is definitively better. Both have their advantages. There are many ways to skin a cat. As we discussed last session, you can obtain good pressure control even with medications and SLT. You might be on a lot of medications, you might even be on tablets, but there are lots of ways you can achieve pressure control. Surgery is obviously one of those. It's kind of the most definitive and most effective. It has a few advantages. I would say, as I mentioned last time, surgery is very effective at blunting the pressure fluctuations. So like I said, a limitation of medications is we tend to lower the average pressure, but we still see the pressure fluctuating up and down quite significantly as the drops go in, etc. Whereas surgery, when you have a new way for fluid to drain from the eye, surgery allows all those peaks to be blunted. And so that's been well studied now, looking at IOP pressure fluctuation in patients managed with glaucoma medications versus those managed with glaucoma surgery. I would say as well, like I mentioned last time, if you're someone who's on lots and lots of glaucoma drops, and you often have a lot of side effects, a lot of red eye, the eyelashes are looking a bit strange, the blink is uncomfortable, you have uncomfortable eyes. I see a lot of patients like this. I would say overall that sort of patient with a good surgical outcome actually has a dramatically improved quality of life after having glaucoma surgery. I did a trabeculectomy just last week on someone who was on 5 different classes of eye drops. And yeah, they said even just after a week after trabeculectomy, they've said that their eye is the most comfortable it ever has been. And so I do see in those more advanced glaucoma that there is actually a quality of life improvement from even having these traditional surgical techniques. So in my hands, certainly MIGS and traditional surgery are both fantastic in achieving a variety of outcomes for the patient. You have to sort of tailor your response to what the patient needs, and I love both. Like I said, I'm the Mitt Romney of glaucoma. Everyone thought I'd come back and be anti-trabeculectomy, but that's actually not the case at all. So first question, let's jump into it. So how do you decide between MIGS versus traditional surgery like a trabeculectomy or a tube shunt? So this really comes down to the magnitude of the pressure lowering versus the safety of the procedure or the risk of the procedure. So in general, when we need greater pressure lowering, we will usually accept a slightly higher risk profile in order to achieve that. It's always a trade-off. And so traditionally, MIGS has been used for patients with mild to moderate glaucoma, with modest pressure reduction, but it's very, very safe. Whereas traditional surgery is conventionally been reserved for advanced glaucoma, and it has very large pressure reductions. However, it also comes with more risks. Now, I would say though that we are seeing this evolution of more sophisticated MIGS procedures. So procedures a little more complex, and maybe combinations of MIGS procedures that allow pressure control that's actually getting very, very close to what traditional surgery like a trabeculectomy can achieve. So there are these hybrid MIGS procedures coming through, and that whole distinction between who needs a trabeculectomy and who needs a tube shunt and who can be managed with MIGS is getting more blurred. I certainly see patients who conventionally I would be consenting for a trabeculectomy or a tube shunt, but who I will actually err on the side of a more complex or sophisticated MIGS procedure because I know I can achieve significant pressure reduction still. They may still be on some glaucoma eye drops, and I'm not forecasting that that will get them out of jail forever, but it may well buy them some time. If they're fortunate, they might be able to postpone having a trabeculectomy for, well, maybe for their life, or we might be able to buy them 3 or 4 years of going without having that sort of more complex traditional glaucoma surgery. So I certainly am now using MIGS, not just in the patients with mild to moderate glaucoma, but also in more advanced glaucoma, to spare them some of the eye drops and maybe buy them some time, avoid them having to jump in straight away for a trabeculectomy or a tube shunt. So there are many factors here to weigh up in terms of whether someone has MIGS or has a traditional surgery. Those are, what pressure do we need? And can we realistically expect to get there with MIGS, even if we use MIGS in combination, like a combination of MIGS procedures or a hybrid MIGS procedure? Other factor would be how much time off work can the patient or the person spend. So there's no doubt that the follow-up after trabeculectomy is much more rigorous and intense than the follow-up after MIGS surgery. What's their lifestyle? So someone who really enjoyed swimming might not be such a great candidate for a trabeculectomy, having a bleb, because they always have that lifelong risk of getting infection through the bleb. So maybe I might err and try to do something a little bit different for them. And also, how healthy is the conjunctiva or the tissues on the surface of the eye? Because if your conjunctiva, you've had lots of other surgery, or it's scarred or very inflamed, then that makes it harder to establish long-term pressure control with something like a trabeculectomy to use the natural tissues to drain fluid from the eye. So I'm just checking my phone here. Here we go. All right. Okay, from Alice, do tube shunts have a lifespan? Can they fail? Can they be replaced? My 2-year-old daughter with congenital glaucoma has them. Okay. Thanks, Alice. So unfortunately, all glaucoma surgery has a lifespan. That is the same for MIGS as well as conventional surgery. I would say the lifespan for a conventional surgery like a trabeculectomy or a tube shunt is longer. It is certainly possible to have excellent pressure control for many years, 20 plus years, with a trabeculectomy or with a glaucoma tube shunt. We don't know that for MIGS, and my suspicion is it's unlikely. In general, MIGS seems to give you good pressure control. We know out to 5 years in some people, and it's probably going to be longer than that, but I do see some wearing off effect after that. Specifically to your question, with a tube shunt, yes, absolutely, it can maintain very good pressure control for a very long time. If the surgery, if the healing response of the eye starts to heal around the tube shunt and starts to build resistance there, then the pressure will rise inside the eye. And that can be managed maybe just with some glaucoma drops if required. You can revise a tube shunt. So there's a couple of things you can do. You can inject some anti-scarring medications around where the fluid is draining to, and then you can release some of that scar tissue. That tends to have some borderline evidence in terms of how effective it is. I certainly do it for some people. You need really big doses of your anti-scarring medicines, and you often have to repeat it several times. Often what you find is the pressure dips very low for a couple of weeks and then comes up as they heal, and you have to do it again a couple of times, but you certainly can win the battle doing that. So all glaucoma surgeries and trabeculectomies and tube shunts can be revised, or I say enhanced, down the track. With tube shunts, it's maybe a little bit more tricky than with other surgeries, and if a tube shunt were to fail, then you would maybe have an attempted revision, or maybe you would move on to something else. But I certainly, the tube shunt is excellent in terms of its robustness. If you had to give an example or ask me to name what's the most robust glaucoma surgery, I would say a glaucoma tube shunt. If you want longevity and with a good technique, really robust surgery that allows you to still do all your sort of normal activities, and tube shunt's fantastic, and certainly for the situation that your child has. So just coming back to my discussion about comparing MIGS, let's say, and different glaucoma surgeries. So you could plot all glaucoma surgeries on a graph. The graph would have the pressure reduction on one axis, and the other axis would be the risk of the procedure. And you could plot every procedure on here in terms of those that are really effective at lowering the pressure might have higher risk, and those that are not as effective as lowering the pressure are safer with less risk. Overall, you need to find a surgical procedure where the risk of that procedure is less than the patient's risk of blindness from glaucoma or risk of visual impairment from glaucoma. It is, however, not exactly linear. It's not like every single procedure, as you get slightly more effective, you get slightly more risk. In my hands, in my experience at least, there are a few little unicorn procedures, or maybe combinations of procedures where I certainly find the risks are very minimal, but you can get a little more pressure reduction than what you maybe would have thought would be possible. And so this is sort of how I look at that, always looking for where the low-hanging fruit is, about what I can get the greatest benefit for the patient for the lowest risk. The other thing about surgery, and why the devil is always in the detail here, is that with surgery, the surgeon does control the risks to quite a significant extent. So even MIGS, where you think we're using a device, it's a really elegant little procedure, it's still someone's hand that are doing it. These are all handcrafted surgeries. There's nothing that's done by a robot or by a machine. And so the risks do depend on the exact technique you do and your experience, etc. So glaucoma tube shunts, we just had a question on that. That would probably be the greatest example of this. In terms of, if you look at the profile, the risk profile of a glaucoma tube shunt, then it can be on superficial level pretty scary. There are some pretty big risks for that in terms of the cornea going hazy, the front window of the eye going hazy, or double vision or other potential complications, which can be serious. However, I would say there's no glaucoma surgery more than a tube shunt where those complications are largely surgeon or technique dependent. And so when we weigh up all these things about benefit versus risks, the other side of the coin when you look at risks is, what is the technique being used and how can we offset or protect against those risks? And there's always modifications of the technique that you can make that can reduce the potential for complications, etc. Okay, so let's move to another question here. These are questions that came in from last week, and we've had some even before the episode today. So my eye specialist has recommended glaucoma surgery. Should I ask for SLT laser first before making the decision for surgery? That's the question. So the glaucoma specialist or eye specialist recommended glaucoma surgery. Should we ask for SLT laser first? So I would say absolutely. Always ask. And I would say that because the principle of informed consent for surgery involves understanding the treatment that you've been recommended, but it also involves understanding all alternatives. And if you feel that SLT is an alternative, then absolutely you should ask, and you should understand why it is that is or isn't being recommended. Now, I'm not saying that because I recommend SLT for you. I'll come to that in a moment. But it's just really important that you always feel comfortable to ask, and I would encourage it because that's how you're sort of partnered into the decision about your care. I would say if your surgeon has recommended glaucoma surgery, and I assume we're probably talking about trabeculectomy or tube shunts here, most ophthalmologists, even glaucoma specialists, maybe I'm a little different, but most ophthalmologists don't like doing trabeculectomies or tube shunts. It's just that they're hard work. They are a lot of follow-up early on, or they can be, Don't have to be, but they certainly can be. And so a lot of ophthalmologists don't actually love doing the surgery. I really quite do, but they can be hard work, and it can also be a little bit of a, I guess, losing face moment for the surgeon, because if the pressure is very unstable after the surgery, which is reasonably common, have high or low pressure as the eye is healing, it can take a lot of effort to maintain the confidence of the patient during that time. And so I think there's always that balance. If your ophthalmologist is recommending surgery, then I would say probably you need it. I'm assuming if they're recommending a trabeculectomy, for instance. I would just say as well, there is a problem or an issue with glaucoma surgery, and this is not my phrase, but it's this concept of masterful inactivity syndrome, and this is not my phrase, so don't hold me to account for this one. But basically, there is a bit of can be a problem where it can be a delay for surgery. So we can have someone on drops who's maybe not ideally controlled, perhaps progressing, play with the drops, try some different drops, try some SLT laser, maybe still progressing, maybe try with the different frequency of drops, try taking this one 3 times a day, taking this one in the morning rather than nighttime, still progressing, and all the while, we're just letting time pass and we're burning these nerve fibers at the back of the eye. And then it gets to a point where now the glaucoma has reached a stage of severity that even a really experienced glaucoma surgeon is a little bit nervous about operating, because they know that just the stress of the operation on the eye can cause the final island of vision to be lost. And so this is a problem. It's not just in Australia, it's talked about at international meetings as well, is in delaying and just trying all these non-surgical therapies too long, because either the patient's concerned or the ophthalmologist is worried about taking the plunge for surgery. That can actually be a disservice, because you can also end up in a situation where now you do have to have surgery, and you're having surgery at a much higher risk time. So I wouldn't defer surgery needlessly unless there's a good reason to, and if your ophthalmologist is recommending it, then probably you need it. So the other thing I would say about SLT is, we talked a lot about SLT last time. SLT is very effective overall, if we take all comers, as an initial treatment, and maybe to reduce some of the medications. But any treatment, when it's used as an adjunct, it becomes harder to demonstrate a big benefit. So for instance, if you come to me and your pressure is 30, then there's so many things I could do to bring that pressure down a long way. Almost anything I do is going to have a bigger response, because 30 is a really high pressure. It's easy to demonstrate a big magnitude of benefit. So to lower the pressure from 30 to 20 is quite easy. To lower the pressure from 20 to 15 is a little harder. And to lower the pressure from 15 to 10 is really hard. Usually requires surgery. So when you're already on, I assume you're already on a couple of medications. And if you're already on a couple of medications and the pressures are maybe bumbling around the sort of mid-teens, 15 or so, then doing SLT is unlikely to have a dramatic impact. It may help blunt the pressure fluctuations, but you would usually see, I would expect, 1 or 2 points at most, not a dramatic improvement. Whereas if SLT was used as first treatment, you see a big response. But when you're already under a lot of treatment and these pathways of outflow are already being enhanced by drops, you tend not to see a big response from adding anything more drops or more SLT. SLT could be used to get you off some drops, but that's really sort of not what we're talking about here. We're talking about getting lower pressures. So just keep all these things in mind. I would just generally say, if your surgeon is recommending glaucoma surgery, then probably it's required. Okay, so I'm just going to talk a little more about MIGS, just because this is where many of the questions are based around today. So, as those of you will probably know, if you've read a little bit about my background, is I was fortunate to be trained by Dr. Ike Ahmed in Toronto, who is basically the pioneer of MIGS. He was awarded the Binkhorst Medal in 2014 for this contribution. So he is kind of the spokesperson that has developed a lot of these techniques, a lot of the stents. And during that fellowship there, all the time, like before surgical lists, we would have different members from industry who were developing the next MIGS procedures, next MIGS stents, and we'd get to play with the different injectors and hand pieces and give feedback on the design of these things. So it was a really, really great unit to be involved in. So that's my background. And I certainly do all types of MIGS procedures. So I don't just do one MIGS procedure, and that's sort of what I want to come to here. Is there are some misconceptions or maybe some slightly misunderstandings about MIGS. The first one would be that MIGS is really just one procedure. There's obviously one or two procedures like eye stents or maybe Hydrus that people have heard of, maybe Zen people might have heard of. Generally, eye stents is the best known. So I just want to emphasize though that MIGS is not a procedure. MIGS is an idea. MIGS is a whole concept. MIGS is a whole phenomenon, and so there are many different procedures. There's around 10 or so MIGS procedures that I can just think of straight away that I was doing, or I do, and I was trained in Toronto, etc. There are procedures that involve stents. There are procedures that are stentless. There are small stents, larger stents. There are stents that go into the trabecular meshwork, stents that go up under the conjunctiva, like a trabeculectomy, or sort of a hybrid trabeculectomy. And up until very recently, there were stents that were going into the suprachoroidal space, which is a whole different drainage route for the eye. So with this in mind, with all these different procedures, understand that not all MIGS procedures are created. I mean, all MIGS procedures are definitively and self-evidently not created equal. That's why it's such a sort of crowded marketplace with so many different procedures. They all have their limitations and advantages. And so this is why it's, we have to really tailor our surgical plan for what the patient requires. And it ranges from very simple, sort of basic MIGS procedures, maybe perhaps very safe, to more sophisticated, complex procedures, or using procedures in combination or hybrid MIGS procedures. And so there's a whole range where you can see different pressure lowering, but also maybe a different level of complexity for the surgeon, or technical difficulty for the surgeon, and maybe potential for a different profile of complications anyway, I would say that. So some other misconceptions is that MIGS doesn't have a lot of long-term data. This was certainly the phenomenon early on. Now we're getting some pretty good data. I mean, we've got good data going out to 5 years. Obviously, that's nothing in compared to trabeculectomy. No new treatment can ever have a data as long as what a pre-existing historic treatment does, obviously. The 5-year data is looking really promising. And so, I mean, I guess it always comes down to how long can you withhold or discredit a line of procedures for just because you don't have that longitudinal follow-up. I think we've now hit that tipping point where it's been well and truly demonstrated that it is an effective MIGS as a phenomenon in all that it encompasses is a durable or effective treatment with some good long-term data, or medium-term data at least anyway. I've already covered this misconception about MIGS only being for mild or moderate glaucoma. There are certainly some MIGS procedures or MIGS-like procedures or hybrid MIGS procedures that can be used in advanced glaucoma. I'll come to some of those in a moment. Another, common misconception is that sometimes MIGS only achieves very small pressure reductions. Again, I mean, it totally depends what procedure you're talking about, who's doing it, what their level of experience it is, how well was that procedure targeted to that patient, what was the prognostication. There are various things you can look for pre-op to give an indication of the success of one procedure over another, etc. The thing about MIGS is it's very, these are all targeted surgeries, so that in general they have a very specific mechanism of action, and they're usually targeting one outflow pathway. And usually, as we know with many procedures of these MIGS procedures, the stents are fairly small. So you have to be placing these stents and doing the surgery in a way that's really going to enhance a viable outflow channel. It's no point just unblocking the drain upstream if the downstream plumbing's all blocked, or opening up some new drain if fluid could never drain there anyway. So these surgeries have to be done in a targeted fashion with some discretion. And I would also say that the channels that we are cannulating or directing fluid down are very, very delicate. And so any scarring or inflammation that occurs afterwards can cause some of those tiny little delicate channels or vessels to close over. And so we are in fact cannulating sort of a vein inside the eye with a traditional, with the eye stents and the Hydrus. But this is a very tiny, delicate tissue, and so it needs to be done in an atraumatic fashion if you're going to see the pressure reduction, but also then a sustained pressure reduction. Otherwise, you could potentially precipitate some scarring in those tissues. All right, how are we going? So let's move on to another question here. So actually, I will just say, so let's say something else. There was a survey done last year by the American Glaucoma Society. So I will share, it's a little interesting. So my boss, Dr. Ike Ahmed, when he first my previous boss, my fellowship supervisor, when he first developed MIGS, he was actually removed from the American Glaucoma Society because it was controversial back then. And it was new. I'm not exactly sure the political reason, but he was actually removed from the American Glaucoma Society. He's since been welcomed back and is a frequent guest speaker with them. But that's a whole long story. There was, just to give perspective here though, last year there was a survey of American Glaucoma Society members. And the survey basically asked them, it was a published survey, and it said, if you have progressive glaucoma, even at relatively low IOPs, would you choose, if you were the patient, would you choose to have MIGS or traditional surgery? And actually the majority of glaucoma specialists who are members of the American Glaucoma Society chose that they would rather have MIGS, or they would choose for themselves to have MIGS rather than a trabeculectomy or a tube shunt. Now that's pretty interesting. The devil is always in the detail though. Like I said, these are handcrafted surgeries. You can have fantastic trabeculectomies and fantastic tube shunts that are going to beat hands down any or maybe almost any MIG surgery. So the devil's always in the detail. But it is interesting though that in general these glaucoma surgeons felt that if it was their own eye, they would still choose to go on MIGS, maybe as a stepping stone, and try and buy them some time before taking the plunge for a trabeculectomy or a tube shunt. I don't want to speak too much against trabs or tubes, because I will just emphasize that a good trabeculectomy or a good tube shunt is fantastic. I would say hands down, a good trabeculectomy is the best procedure you can have if you need low pressure control. And I've used a lot of other procedures, that can achieve similar pressure. But a trabeculectomy is fantastic. The issue is that it can be a bit of a rocky course early on, and in order to achieve that fantastic trabeculectomy, there will be a number of other patients who have an okay result, but not fantastic. And so it's all about achieving the consistency of the outcomes, and this comes from surgical technique, and it comes from selecting the best patients for the best procedure. And now, there are mixed procedures, hybrid mixed procedures coming that are doing some of the steps of these traditional surgeries to smooth out that post-operative course and achieve more consistent results. Anyway, all right, so we've got a question here from Brian. Brian writes in to say, these are questions that were sent in last week, by the way. Brian writes in to say, how effective are eye stents? My drops are annoying, but I'm not up for the full drainage surgery yet. Okay, so how effective are eye stents? My drops are annoying, but I'm not up for the full drainage surgery yet. Okay, and by drainage surgery, we're referring to trabeculectomy or tube shunt, or some of the other traditional glaucoma surgeries, which are things like deep sclerectomy and abexternocanaloplasty. That's a whole nother discussion. We won't go there today. But so coming back to your question, Brian, how effective are eye stents? Okay, so to judge effectiveness of a MIGS procedure, you can do it in a couple of ways. You could quote a big study, and if you quote the results of a big study, then you have to also discuss the limitations of that study. So if you ask me to design a study to show, I could design you a study that's going to show fantastic result of a MIGS procedure, or I could design a study that's going to show a fairly poor result of that same MIGS procedure. It all comes down to patient selection and what patients you're enrolling and not enrolling. So to quote one study, I always feel is misleading, because you have to look at who were the patients selected, what were their pressures, what were the treatment, what was actually done, and how well do those study results translate into the patient sitting in the chair in front of me. So I don't think it's the best option just to quote one study. I think the best way to do it is to take a lot of studies, look at a lot of studies in group, and then kind of summarize and get a bit of a feel for it. Overall, if you look at a large number of studies, then in general, then 2 eye stents would achieve pressure in sort of the mid to the high teens, roughly. Now, there's a lot of variation in that. You'll get some people who really don't get much response at all. You'll get some people who do well. There was a study suggesting that 2 eye stents is approximately equivalent to the drug Glaucoma. Glaucoma is pretty similar to Ganfort or Duotrav, sort of. So that gives you some idea. I don't always see an effect quite as big as that. It can vary, and that's where it all comes down about selecting the procedure for the patient. Let's just discuss eye stents a little bit more, because it's at the moment it's still what most ophthalmologists, even what most glaucoma surgeons will do. There are certainly some people in Australia who are doing a variety of things, but still it's the market is fairly dominated by most ophthalmologists are just doing eye stents at this stage. There was a glaucoma meeting last year, actually in Queensland, and when they did an audience poll, there were only 3 people in the room who were doing more than one MIGS procedure. So most ophthalmologists just last year were still just doing one MIGS procedure. I think that'll change, but let's just talk around it for a little while first. So, I mean, as I already mentioned, that MIGS is a really broad umbrella term. So we shouldn't think about discussing MIGS just in terms of one procedure. You have to keep an open mind. There are lots of different things. It's a changing landscape, and you can use these procedures in a range of ways. It's expanding, that's for sure. So, just on eye stents, because you'll hear it talked about so much, what does an eye stent offer? An eye stent does offer the longest data. So they were the first MIGS procedure that were approved by the US Federal Drug Administration. So they have a long history of data. They do have very excellent safety data, no doubt about that. I would say, in my hands, I can't imagine. I can't imagine how I can harm someone with eye stents. I've certainly seen complications with eye stents. I find it really hard to imagine how I can cause a complication with an eye stent. I couldn't really say that for any other MIGS procedure, even though I do a lot of other different procedures. So they're very, very safe. The surgery is very elegant. It's fast. It's very efficient. It's fairly simple. And so surgeons like doing it. I think you would find that all other MIGS procedures are a little more technically challenging, and so surgeons would usually start with doing eye stents, and some of them may move on to doing some other procedures. But that's why you see part of the reason that a lot of surgeons do offer eye stents at this stage. So, in terms of effectiveness, though, no. I mean, we talk about the balance in terms of effectiveness versus risk. Eye stents offer some unique benefits. In most effectiveness, well, I think it's demonstrated there are some more effective procedures, and it's all about tailoring the procedure to the patient. In my practice as a glaucoma specialist or subspecialist, I see patients who generally need the most pressure reduction they can safely obtain, and therefore I tend to do a variety of different procedures for the patient and even some procedures in combination. So, just in summary to your question, Brian, how effective are eye stents? So, in isolation or with cataract surgery, hopefully should achieve pressures around the mid to high teens. Not everybody, hopefully that'll be you, but that's sort of what the evidence would suggest. Drops are annoying. I'm not up for full surgery. I agree. I can understand that totally. You may be really happy though. I mean, like I say, a good glaucoma surgery, good trabeculectomy is fantastic. And like I said, my patient last week who, lots of eye drops, very apprehensive about having anything done. Already the eye's feeling more comfortable than it ever has, and it's less than 1 week post-op trabeculectomy. All these things about bleb dysesthesia and discomfort and pain and aggravated dry eye, those are kind of offset when someone's on 4 or 5 glaucoma eye drops and their eyes are really red and inflamed. So you never know. The drops are a nuisance, but maybe maybe you will be happier after if the surgery goes well, and you can get off some of those things too. All right. So just how many different glaucoma surgeries are there? So there's lots of different glaucoma surgeries that have covered this. There's about 10 MIGS procedures alone. Comparing these different surgeries is always tough. So the best way to compare would be to take a group of patients and split them and have half of them have one procedure, half have the other procedure. Make sure the patients have generally matched, they're similar patients, and then study them and follow up how they go. But that's really, really hard and expensive to do, and it's also slow to do. It takes years to get the study approved by ethics, enroll all the patients, and follow up. So in general, we don't have a lot of good comparative studies. We have some, but it's really hard to compare definitively these different procedures that we have. So my approach has been to look at the basic science of the way fluid drains from an eye. So last year, with a couple of other co-authors, I published a review. So we basically pulled back all those studies back from like the 1940s and 1950s. So this is the time when understanding the physiology of the eye, how fluid drains from the eye, that was the time when this was hot, back in the 40s and 50s, up until about the 1980s, and then it kind of went quiet. Things moved on to other fields. So it's very interesting to dig up these studies, beautiful papers, and actually look at what the studies actually showed. Because over time, the story and the history kind of gets lost. And so what we think we understand is actually maybe not the full facts. And so we wrote a review article basically summarizing how fluid drains from an eye, what the rate limiting steps of that drainage pathways are, and therefore how different MIGS procedures enhance different aspects of the outflow, and how you can sort of compare them on a biological plausibility viewpoint. And so that's sort of where I am at the moment. Obviously, I look at outcomes too to compare, and we do have some comparative studies, but I think it's going to be a very, very, very long time before we have really good comparative studies, because they're just so expensive and so hard, and we have new procedures appearing all the time. So in my mind, I'm always thinking about what is biologically plausible to work best here, based on the severity of glaucoma, the subtype of glaucoma, the specific examination findings, and then what the patient wants, their lifestyle, etc. So yeah, so those sort of things. I think if you're in deciding this, I really think it is very difficult for patients at this time. Ideally, you would want, you want the best possible outcome that you can possibly attain. There is a new code coming through, a new MBS funding for a new item number coming through that's going to be for standalone MIGS procedures. So this is MIGS procedure without cataract, because up until now we've just only really been able to do MIGS at the time of cataract surgery. But there's so many patients out there who either don't have a cataract or who have had cataract surgery, but maybe didn't have a stent, or they're still on glaucoma drops and they would really benefit from something being done. There's no way that at the moment we can give them a MIGS device or MIGS procedure and have a Medicare partially fund that. So this is a new Medicare code, and I've been appointed to the committee that's looking at how we're going to use this code. It's really, really important time for glaucoma. Australia is the first country on earth to have this code or have government funding for standalone MIGS. So our data is going to be really important. It's really, really important that we demonstrate good cost-benefit outcomes from this. And so obviously there is a cost for the surgery, and we want to see that translate into less glaucoma prescriptions and less trabeculectomies and tube shunts being done. And so a really big part of this is making sure that these procedures are targeted in a way that's most effective. And so access to this code is actually going to be restricted. Like I said, I've been appointed to a committee of around 10 other ophthalmologists around Australia who are going to have guidelines or oversight into which glaucoma specialists would have access to it. The proposed guidelines, I would have to be a surgeon who does a lot of trabeculectomies or tube shunts, so has experience with the fallback option with MIGS, but also has a lot of experience with MIGS procedures, and ideally a variety of MIGS procedures. What you really want is you want someone who, or you want this done in a targeted fashion. So a variety of MIGS procedures available, a variety of surgical options, and things are done in a targeted fashion rather than a sort of cookie cutter approach. And so that's something interesting. Maybe we can come back and talk about that. That will be a concept in evolution over the next few weeks. And I saw actually there was a post from Glaucoma Australia about it this morning. So that's certainly a very, very exciting time for glaucoma patients around Australia. And it's good to see that we are leading the world, in fact, in that realm, in standalone. And our data is going to be really, really valuable for the rest of the world. Okay, so next question. So my glaucoma is under control with the use of eye drops, but I am having my cataracts removed soon. Should I still consider a combined cataracts and glaucoma surgery? So the glaucoma is under control, so pressure's good. Okay, pressure's good. So should we still have MIGS done at the time of surgery? Interesting. Okay, so personally, if you were my patient, I would 100%, I would love for you to have it, because as we know, the drops do cause side effects over time. They're a nuisance. They come at a cost, to you. And we know that pressure fluctuation is a thing in glaucoma, particularly as the disease progresses or over time. The pressure tends to become more unstable. So ideally, if it was my eye or if I was you, yes, I would have MIGS. Now, we do need to demonstrate before Medicare would co-fund that. We have to demonstrate that you're intolerant of drops or you're having problems with drops. So if you were having side effects from the drops, then that would be reasonable. If you like the drops, they're no imposition to you, you're doing great, you're not getting side effects, then, probably no great reason to have MIGS in that regard. You probably don't really need it. Sometimes, if your glaucoma was advanced, then doing MIGS at the time of cataract surgery does certainly smooth out the post-operative pressure fluctuations. So when we do cataract surgery in anybody, we do see the pressure fluctuate early on, those first few days. If the glaucoma was very advanced, then sometimes those pressure fluctuations can get really out of control in certain types of glaucoma. And so doing a MIGS there can certainly blunt out the pressure fluctuations. And that would be one other consideration. But that's getting to minutiae there. But overall, yes, I would recommend if you are having problems from your eye drops, having some side effects, if they're bothering you in some way, then I think MIGS, you're a great candidate for MIGS. And I also would just go on to say, personally, I think it is now becoming negligent. It's a strong word, but it's becoming negligent to have a patient who's on glaucoma eye drops and consent them for cataract surgery and not discuss doing MIGS. And this is because the data for MIGS is pretty strong. And as a part of informed consent, we have to discuss, or we should discuss, the treatment that's recommended, but then alternatives. And the alternative, there's always an alternative to do nothing, by the way. So that's always something I would discuss. What's the risk of doing nothing here? But if you're having cataract surgery and someone has glaucoma or they're on glaucoma drops, then an obvious alternative is just do the cataract, or while we're in the eye anyway, and while we're placing an intraocular lens, while we're placing one prosthesis, why not just place a second small prosthesis, a small implant, which is a glaucoma implant, and hopefully get you off those drops or improve the pressure control. You have to have that discussion. It's really important. I think the data has passed that point where it's now reasonable just to totally admit that or omit it. And now it's important that all ophthalmologists around Australia should really be having that discussion with their patients who have glaucoma and are going for cataract surgery. That's my thoughts, but I think there's loads of people that would be of the same opinion as me on that one. Okay, we're doing pretty well for time here, guys, actually. Okay, so this next person asks, I have heard that removing cataracts can lower my eye pressure. Does this mean that I won't need glaucoma treatment after cataract surgery? Really good question. Okay, really good question. So, does removing cataracts lower eye pressure? So this came about, the big study to show this was a study called the Ocular Hypertension Treatment Study, which was a really big study in patients who have ocular hypertension. So that means high pressures, but they didn't actually have glaucoma yet. They had all their vision and their optic nerves were fairly healthy. When they looked at that study, it was a big study in the USA, they looked at all the patients who had cataract surgery in that study, they noticed a big drop in the pressure after cataract surgery. And that was kind of one of the big first publications, big signs that cataract surgery in itself is kind of a glaucoma procedure because it lowers the pressure. There were some other studies as well that if you suggesting that the overall pressure in the pressure reduction from doing cataract surgery is around 10 to 34%. However, here's the thing. Devil's always in the detail. That's if you take all comers. All patients having cataract surgery, yes, on average, there is a pressure reduction just from doing the cataract surgery. However, if you tease out the patients into the different groups, then it's really just some groups that benefit, whereas others don't benefit very much. So the big group that benefits are the ones that have slightly narrow drainage angles. They don't have to be closed, but just narrow. So what do I mean by that? So there's the cornea, which is the clear window of the eye, then there's the iris. And they join in the corner, which we call the anterior chamber drainage angle. And the drainage channels of the eye are right in that corner, at the base of the cornea, at the junction between the cornea and the iris. Now, a cataract is a lens that gets thicker and thicker, and that pushes the iris forward such that the drainage channels start to become very narrow. Now, we just know from looking at large numbers of patients that patients who have a very shallow front of the eye because the cataract is moving forward and now the drainage channel is becoming narrow, they have a great pressure reduction from cataract surgery, and they're the biggest ones to benefit. The other groups are those that have some secondary glaucomas, so things like pseudoexfoliation glaucoma or pigment dispersion glaucoma, just the fluid dynamics inside the eye and the kind of, washing effect of doing surgery inside an eye, that can probably help to release some of the debris in the trabecular meshwork. So those patients are the big groups. If you just have primary open angle glaucoma, which is by far the most common type of glaucoma in Australia, if you have primary open angle glaucoma and your drainage channels are wide open, fluid can get to them easily, then we know that doing cataract surgery only has a small benefit, and the benefit tends to be fairly transient, wear off over a couple of months. So, all these things, it comes down to what your risk is. Certainly, if I do cataract surgery in someone with very shallow drainage angles, and they don't need much pressure reduction, I might not even do a MIGS procedure because I know my cataract surgery is going to lower their pressure quite substantially. However, if I was doing cataract surgery in someone who had primary open angle glaucoma, the drainage channels are wide open, then I wouldn't be expecting much pressure reduction just from doing the surgery alone. And so that would be more in favor of doing a MIGS. So all these things, the devil's always in the detail. I hope that answers your question though. We've had a few more get texted through just then. Okay. From Lorraine, can tube shunts work on severe dry eyes and narrow angle glaucoma? Okay. So can tube shunts work on severe dry eyes and narrow angle glaucoma? So just the dry eyes first of all. So any surgery is going to make dry eyes worse, at least in the short to medium term. And that's because we have to clean the eye with antiseptics that are really quite toxic to the mucus secreting cells of the eye. And so those antiseptics will make the dry eye worse. Having the surgery, having the eye exposed and maybe drying a little bit during the surgery, all the post-operative drops with their preservative in them, they all make the dry eye worse. So everyone with dry eye is going to get a dip and get worse with their symptoms early on, and then it will start to recover over weeks or sometimes many months. So no matter what you do, it's going to get worse. What's the best? Tube shunt. I do like tube shunts though over trabeculectomy in severe dry eye, because the difference is a tube shunt is shunting all that fluid way back behind the eye, whereas a trabeculectomy is draining that fluid right up near the front of the eye, right near the eyelid margin. And so if your eye is dry, it means you're relying on the fluid to drain into this tissue, this bleb, this little blister on the surface of the eye that drains the fluid. That's all happening right where the eye is dry and it's uncomfortable and inflamed. So the trabeculectomy tends not to do as well, and often maybe slightly higher risk of infection too. So tube shunt, good option if you have off-surface disease or very inflamed eyes. Can it work in narrow angle glaucoma? You would need to open the eye, create some space in order to do a tube shunt safely. So it certainly can, but in my hands, I would always remove the cataract first, or the lens inside the eye if you haven't developed a cataract. So do cataract surgery, which removes the big, thick, natural lens of the eye, about 5 millimeters thick, replace it with a very thin artificial lens. That creates a lot of space in the eye, so now the eye can breathe again. And then that gives you space to put the glaucoma drainage tube in. And this is where I come to my point before about different surgical techniques and different risks. You can put the tube in front of the iris, or you can put it behind the iris. You can do a range of different things that has each advantages and considerations. So yes, tube shunt for narrow angle glaucoma, certainly. I would remove the cataract first to create some space in the eye. Otherwise, it's going to be very crowded. And, dry eye, tube shunt's a great option. Okay, so from Adrienne and Susan. Okay, if my IOP is already in the low teens, should I have surgery or should I stay with eye drops? Okay, Susan has some surgery upcoming. It's scheduled, but she's now unsure. If my pressure is in the low teens, should I have surgery or stay with eye drops? It's really tricky to answer that. Depends on whether your glaucoma is controlled or not. Some people need a pressure of not of low teens, like 12 or 13. They need a pressure of 8. And I would say there's no way you reliably keep a pressure of 8 without doing surgery. So if your pressure is currently in the low teens and it needs to be 8, then you need surgery. If the pressure is currently in the low teens and it just needs to stay in the low teens, then the benefit of surgery would be to reduce the medication burden you need, reduce the number of glaucoma drops, which reduces your side effects of those. And then there's that other benefit that's not as well known, but it's definitely a thing, is it will help to smooth out the pressure fluctuations. So patients who have pressure that's well controlled, who have more advanced glaucoma, typically or often the pressure is actually not nearly as well controlled as we think. And if we measure their pressure over 24 hours, we see that the pressure fluctuates quite a lot. It just happens that during office hours, once they put their drops in, come to see their ophthalmologist, the pressure is pretty good then, but outside of office hours, particularly overnight while we sleep, the pressure can be quite unstable. And so I often do these sort of tests to check for this. I think it's important. Glaucoma surgery would offer you the benefit of it blends out those pressure fluctuations. And so even if after the surgery, you say, oh, my pressure's 12, but it was 12 before the surgery, what's the benefit? Often I could demonstrate benefit in showing that, yes, it was 12 at 10 a.m. before, but it was fluctuating a lot, maybe up to 20 every night, whereas now it's a smooth 12. It's 12 all the time, which is a massive difference. And so I hope that answers your question. All right. keep them coming. We've got how many more minutes? Maybe another 10 minutes or so. Let me see what other questions we have here. All right. A question about recovery period from MIGS versus trabeculectomy. Very simple. Yes, MIGS, fast recovery in general. A lot of my patients are up driving the next day. Usually you can do most things pretty quickly. Trabeculectomy, different kettle of fish. You need to quite multiple post-operative reviews. Pressure often fluctuates quite a lot early on. Might have to do little adjustments to the surgery or adjustments to the eye drop. So they're completely different in terms of the recovery. MIGS is obviously much faster recovery in general than what trabeculectomy is. Okay, I've heard that MIGS is better than trabeculectomy. Is that true? That's the question. I've heard that MIGS is better than trabeculectomy. Is that true? And the other question that came through from Deborah actually was, are trabeculectomy surgeries being replaced by other new surgeries? Good question. Okay, so in my fellowship in Toronto, where I was with University of Toronto, that was the center that pioneered the MIGS procedures that we now use, basically. Okay, in that fellowship, we have a lot of advanced glaucoma patients coming to that unit. Really advanced glaucoma patients, seen multiple ophthalmologists, coming for a fourth opinion, maybe had several surgeries before. Really, really common. I will say in my year in Toronto, we did very few trabeculectomies. We used mostly other procedures, which are just starting to come to Australia or will be coming here soon. Other procedures that are kind of these hybrid mixed procedures or trabeculectomy-like procedures. Still, I've also trained in my first fellowship was in New Zealand, where we did a lot of trabeculectomies and tube shunts. And so I see both sides of the coin here. Trabeculectomy has advantages. And so, is trabeculectomy being replaced by MIGS? I think it is to an extent. There will always be a role for traditional surgery, I'm sure of that. But we're going to see more and more of these MIGS procedures and hybrid MIGS procedures, trabeculectomy-like MIGS procedures coming through and at least substituting for some of the surgical steps of a trabeculectomy, and therefore hopefully achieving more consistent surgical results and a smoother post-operative course than what a standard trabeculectomy would do. I actually published an audit of all glaucoma surgeries and all glaucoma prescriptions in Australia over the last 15 years. So this was a cool project, actually. I had a colleague who phoned me up saying they wanted a research project. They needed something fast. And so we needed something that didn't require ethics review, could be done after hours, and would have impact. And so what we basically did is download all the PBS prescriptions for glaucoma medications and all the MBS item numbers, so all the surgical codes for glaucoma that have been used in Australia over the last 15 years. It was an Excel spreadsheet with over 1 million rows of data, but from that we're able to show trends in how things are changing over time. And that did reveal that actually trabeculectomy surgical rates are starting to dip. And so this could be a combination of things. You could argue maybe MIGS are coming in and more patients are having MIGS, and therefore they're putting off the trabeculectomies, or they're not needing trabeculectomies. Maybe MIGS and a couple of drops is getting them by. Or it could be that maybe we're still getting we've had some more potent drops arrive in the last 7 years, and maybe that's put off a few trabeculectomies. I'm not exactly sure. But the standard traditional trabeculectomy rates are declining in multiple countries around the world, including Australia, Canada, and Great Britain. But I still love trabs. I'm not anti-trabeculectomy, okay? I love both procedures, MIGS and standard surgery. Okay, we've got any more questions coming through? Maybe I'll handle one more here if you like. This is one from Judy. I'll have this one as a detailed question. Judy wrote in last week. She said, I'm 73. I have normal tension glaucoma 2.5 years, and I've lost some visual fields. I've trialed 6 eye drops. All were unsuccessful. I either have allergic reactions or I get severe pain. Had SLT laser to both eyes, which helped, but for a short time only. I even tried Diamox tablets, but had a reaction to those. I know of stents, but I'm worried that I would react to something that isn't natural. My question is, where should I go to next? Okay, so we've got normal pressure glaucoma, which means that Judy has suffered glaucoma damage to the optic nerves, despite having pressures that are sort of within the normal range. She's lost some visual fields, can't tolerate eye drops, has reactions to eye drops, has reactions to tablets, didn't have a great response to laser. And so where do we go? So a couple of things here. Always, the first question in my mind is the glaucoma stable or is it progressive? I ask this because normal tension glaucoma tends to divide into two categories of patients. Those who remain fairly stable with little or even no treatment versus those that quickly progress and need really strong treatments in order to save their vision. It's really like dichotomous. And so first of all, my standard approach is I actually don't initiate treatment for normal tension, normal pressure glaucoma patients unless they show progression or unless they have a visual field defect that's starting to threaten their central vision. And that's in accordance with the largest study that was ever published in normal tension glaucoma back several years ago. So I tend to always watch normal tension glaucoma patients first, follow them very closely to see if there's someone who's stable and I can just leave alone, which would be fantastic, or to see if in there that other group of patients who's going to get worse and I really need to be on quickly and intervene with something really effective. I'm just going to assume that you're someone who does need treatment here because your ophthalmologist has trialed 6 eye drops, Diamox, and they're not mucking around. So, where to next? You asked about reacting to glaucoma stents because they're unnatural. So this is something that gets circulated. I have personally never seen or heard of a convincing case of anyone reacting to a component in the available glaucoma stents that we have at the moment. And I talk about the main ones we're sort of talking about here would be iStents and Hydrus. Let's just say that. Now, iStent is made out of titanium. Hydrus is made out of nitinol. Nitinol is a titanium nickel alloy. Titanium nickel alloy. Now, I just mentioned that because it has nickel in it. Some people react to nickel. We've never heard or seen of anyone actually reacting to nitinol. Nitinol is a material that's been used in thousands of cardiac stents and used in various stents of the body and vascular stents, etc. So we have long data, safety data for nitinol. Both these materials sit well with the eye. I really would not be concerned that you are going to react to a material in the stent. That is vanishingly unlikely, in my opinion. That would be worthy of publishing in a journal, a high-value journal, if there was truly a reaction to a material in the stent. Because I've certainly never seen that sort of thing convincingly demonstrated. Yeah, I think if you can't tolerate drops and medications and laser, then you need some surgical treatment, and it's a question then of MIGS, a stent procedure, or do you have MIGS without a stent? There are MIGS procedures that don't involve a stent. Some of them really effective, actually. Maybe that's more, what you would like. Or do you have a traditional surgery like a trabeculectomy or whatever it is that's going to be best for you? I'd have to meet you to understand. But yeah, I think that's sort of what you're looking at. But I wouldn't be concerned about reacting to the material in a stent. All right, we just got a text. I think we're going to try and... Good, okay, yeah, let's try and wrap this up. So I'll circulate some ideas for another session. And I've got a few I'm thinking of already. So we'll put these out there and see what you think. But anyway, it's been a pleasure chatting with you today. Hope that's been full. Feel free to write in any more questions, and I will. I'm happy to answer them in the comments following on from this later night. All the best, guys. We'll catch up again.